Hi everyone, I'm Dr. Windsor. Thank you for joining me for another lecture. In this lecture, I'm going to be talking about medication administration as it specifically relates to the role of the surgical technologist. By the end of this lecture, you will be able to define terms and abbreviations associated with medicine administration, identify the role of the surg tech in medicine administration, explain the 5 rights, list and discuss the steps used to identify medications in surgery, explain aseptic techniques used when delivering and receiving medications onto the sterile field, describe the process of labeling and handling medications, identify the supplies that are used, and lastly, you will have a better understanding of sharp safety in relation to medication administration. So before we dig in, I want to remind you that the limits of legal authority for the surgical technologist to perform indicated roles that we're going to discuss are controlled by each state through its statutes, case law, regulatory law, attorney general opinions, and medical licensing boards. First, it's important to always remember that drug administration regarding the sterile field is a team sport. The surg tech plays a significantly important role in the process, and I'm willing to go as far as to say the ST is essential when it comes to the proper administration of drugs to the sterile field. In the operating room, it is typical for the circulator to retrieve and dispense the medications to the surg tech at the sterile field. After receiving the medication, the surgical tech prepares and hands the medication to the surgeon. The ST is also responsible for tracking the amount of medication that is used and reporting it to the circulator at the end of the case. It is critical that we remember that it is never within our scope of practice to administer medication to the patient. If we are ever asked to do this, we need to politely remind the individual that it is not within our scope of practice, but that we are more than happy to find someone that can assist them. Each team member in medication administration has a particular role in the process, and we're going to learn more about that next. So like I previously mentioned, medication administration from the sterile field is definitely a team effort. The surgical tech sometimes might serve as the assistant circulator in the non-sterile role or the first scrub in the sterile role. However, if you are going to serve in the assisting circulator role and administer medications to the sterile field, you need to be sure to communicate to your circulator that you are going to do this. You want to let them know which drugs you're giving to the first scrub. In my experience, some circulating nurses don't like you to do this, so be sure that you ask them first. Now, the circulator/assistant circulator has 3 main duties regarding medication administration from the sterile field. First, they obtain the correct medication. They're going to check the label to make sure that it is the exact drug and strength as what is listed on the preference card. It's also a best practice to also check over the integrity of the container as well as look at the expiration date. Then they are going to deliver the medication to the sterile field using strict aseptic technique. Now, during this time, the circulator and the ST are also going to verify the medication together. Now, this is off the record, but sometimes circulators exhibit sloppy technique, and you might be wondering what you can do in this situation. My advice is to always approach the situation with kindness. One thing that I have experienced often in these situations is that the circulator will try to reach over the sterile field to deliver the medication. One way you can avoid this without saying anything at all is to simply pick up the cup or the basin and move to a position where the medication is not being delivered over the sterile field, like past the end of your back table, for example. Now, the other main duty of the circulator is going to be to document all medications that are used on the sterile field. Now that we have a better understanding of the role of the circulator, let's talk a little bit more about the ST's role in medication administration. So during the identification process, if anything is of question, the integrity of the package, the label is hard to read, there's something fishy with it, you should discard it right away. Always go by my favorite principle: when in doubt, throw it out, right? Once the medication is identified, the search tech is going to accept the medication or medications from the circulator. The accurate identification and immediate labeling of all the drugs accepted onto the sterile field is going to be really crucial. This is going to ensure that medications are not labeled incorrectly, or you just get busy and you forget to label it altogether, right? Incorrect labeling of medications can have catastrophic consequences for the patient. I had a student that was on his clinical and he accidentally switched the labels on the lidocaine and the heparin. Imagine how this would have affected the patient if the circulator didn't catch the mistake. So this resulted, sadly, in the facility asking him to be removed from the clinical site. So I'll say it again. All medications on the sterile field must be labeled immediately and correctly. Also, don't take the circulator's word for it that they gave you a certain medication. This is not a best practice. You want to demand, in a nice way, to see the medication label, right? Not that we have trust issues, but we have trust issues, right? There's checks and balances, and we want to make sure that we are using those checks and balances to make sure that we keep the patient safe. Again, if medications are not clearly identified and you're questioning what they are, you need to discard them immediately and replace them with new ones. When in doubt, throw it out. The ST is also going to pass medications to the surgeon. And when you pass the medication to the surgeon, you want to verbalize the name and the strength of the medication as you pass it. I know that there's a label on there, but you also want to verbalize the name and the strength as you are giving it to the surgeon. Even if it's saline, when you pass it to the surgeon, you say 0.9% saline, okay, or sodium chloride, whatever the case may be. The last thing on the list here is that, like I said before, it's our responsibility as the surge tech to report the amount of medications used on the sterile field. So now we've talked a bit about the role that the surge tech plays in regards to medication administration. Now I want to talk about something called the 5 rights. So to reduce the occurrence of medication errors, the 5 rights of medication administration were established. And if you look in your textbook in box 4.2, you're going to see the 5 rights listed there for you. The 5 rights are the right drug, the right dose, the right route, the right patient, and the right time. Giving the right drug means that you know which drug is required. How do we find that out? We look on the preference card, right? The right dose refers to the amount and concentration of the drug that is required. How do we know that? We look on the preference card, right? We also want to make sure that we are using the right route as per the label when administering the medication. Now, this information should be alluded to on the preference card as well. And it's imperative that we make sure that we verify the patient to ensure that we are giving the drug to the right patient. And then lastly, the right time refers to when the drug will be administered. So we're going to talk about each of these in a bit more detail on the upcoming slides. However, it's important to remember that team members must work together to make sure that the 5 rights of medication administration are achieved and to not get complacent or too busy or try to skip steps. This also means that we need to hold one another accountable, which isn't always that easy, right? But if you see someone doing something that is questionable, it's your responsibility to say something. So as I mentioned previously, the first right of medication administration is right drug. So again, where do we go to determine which drugs are needed for our case? The surgeon's preference card should provide us with that information. Preference cards may be electronic or they may be handwritten. Either way, it's really important that medication names are spelled correctly and or written correctly and legibly. We also need to check the medication's label carefully to help ensure that the right drug is being used. Once the medication is on the sterile field, we need to label it immediately, and that includes all containers that the medication comes into contact with, whether it's a syringe, a cup, a basin, or a combination thereof. Oftentimes, another checkpoint to ensure that we have the right drug is during the timeout. The surg tech will verbalize the medications that are on the sterile field. Another way to ensure that we have the right drug is to always say the name and the strength of the drug when we're passing it to the surgeon. It's also a best practice to keep the medication vial in the room to help ensure that the correct medication is used. Medication vials serve as evidence that the proper medication was delivered to the field. We want to be really careful when we're saying drug names because some drug names sound a lot alike or they are spelled a lot alike. Some examples are Pitocin and Pitressin, epinephrine and ephedrine, Tobrex and Tobradex. Again, if there is ever any question about a medication that you're using on the field, you want to throw it out and get new. When in doubt, throw it out. A side note here is that I have had experiences where the surgeon or the circulator wants to rush me when it comes to identifying or labeling a medication. Please don't let them do this. I know it can be an unnerving situation when the surgeon is standing there tapping their foot, waiting for you to get the medication and verify it and label it and get it into the syringe and, all of those things. You want to make sure that you do not let the surgeon rush you when you are labeling your medications. Allowing that to occur is how mistakes get made. And patients are the ones that are going to suffer the consequences. The second right of medication administration is right dose. The dose is the factor of both its amount, the amount of the medication or volume, and the strength, which sometimes we refer to as the concentration. Written protocols are sometimes instituted and posted to eliminate common confusions about medications. Heparin is a good example here. Heparin comes in a variety of strengths, such as 100 units of heparin per ml or 10 units of heparin per ml. If we were to accidentally give one over the other, there could be serious consequences. So correct labeling is really crucial. Legibility is equally as important, as this serves as written communication of the drug in the container or the syringe or whatever. You want to ensure that anyone else can read your label. For example, you may be relieved for lunch or to go home at the end of the day during a procedure, and whomever relieves you must be able to read your labels. So sloppy writing is risky business. So write legibly, please. And it goes without saying that getting the dose right is vital. The surgical tech plays a key role in the prevention of administration of the wrong dosages of medication from the sterile field. We are ultimately the final checkpoint prior to passing that medication to the surgeon. Also vital to medication administration is the third right, which is right route. Most medications administered in surgery are going to be given intravenously, usually by the anesthesia care provider. However, several additional medications are given by the surgeon at the field via injection or topically or instillation or what have you. Different administration routes require different preparations or concentrations of medications, and this is where, again, it's really important that we read the preference card. So, for example, you might have a preference card that calls for 2% lidocaine jelly to be used as a topical anesthetic during a cystoscopy. So reading the label carefully is going to reveal that it is for topical use only. Now, the preference card might not specifically say topically, but we know that a jelly is used for topical use. Another example is the use of corticosteroid, which I think I've mentioned before, but there are two types. One that is made specifically for use in the ear, and the other that is only for the eye. It's also important to note here that we don't want to use any medication in the eye unless the label specifically says that it is ophthalmic. A careful reading of the medication label is going to give us the information necessary to determine the right route. Getting the drug route and purpose right are extremely important because an error could prove fatal for our patient. Another situation that can occur is that you have two different strengths of the medication on your back table. Most of the time, the medications we have on the back table are clear, and we're not going to be able to tell them apart from one another. This is another reason why correctly identifying, labeling, and handling of medications is so critical. So let's say that we are scrubbed in on a procedure of the middle ear. Typically, for these procedures, we have two strengths of epinephrine on the field. Topical epi, 1 milligram to 1 ml, which is a 1 to 1,000 ratio. And then local anesthetic, maybe 1% lidocaine, that's 0.001% epi. If we're to get these two confused and inject the topical one, the patient would experience tachycardia and hypertension, which could ultimately lead to cardiac arrest. And this was the case on December 15th, 1995. There was a 7-year-old boy that was having ear surgery. What was thought to be lidocaine was injected at the surgical site. The boy started experiencing tachycardia, hypertension. He went into cardiac arrest and they tried to resuscitate him, but despite the team's best efforts, he did not survive. When they did an investigation, the cause was identified as an unlabeled syringe containing only epinephrine. So this is why we never want to put topical epi into a syringe. Instead, to avoid the chance of it getting injected, we want to always place it in a shallow dish of some kind. I call this booby trapping myself. The fourth right of medication administration is the right patient. And the patient and procedure are identified prior to the transport to the OR. But tools such as the Joint Commission's Universal Protocol and the WHO Surgical Safety Checklist are going to be tools that are often used to ensure that the correct surgical procedure will be performed on the correct patient. A history of drug allergies or hypersensitivity should also be included in the patient identification. I have found that it's best to inquire about drug allergies or sensitivities prior to opening the supplies for the procedure. So just before the surgeon makes the incision, the surgical team pauses for a timeout, right? And during that time, the team verifies once more that they have the correct patient and they are performing the correct procedure. Other ways the surgical tech can help reduce medication errors is by heeding the fifth right of medication administration, which is right time. So this isn't as difficult in surgery because the surgeon is there and they're going to be the ones that administer the medication from the sterile field when they want them to be administered, right? So for example, if the preference card requests 1% lidocaine for local anesthetic, then there's a good chance that the right time for the surgeon to administer it is before they make the incision. The surgeon may also ask for additional local periodically throughout the procedure. If the preference card indicates that the medication is to be used for postoperative pain control, then the right time for the surgeon to administer it might be right after they've closed the wound. Let's say other medications such as contrast or heparin or antibiotics are prepared and readied on the back table during the setup, and then they're going to be passed to the surgeon at the appropriate requested time. Similarly, the surgeon may verbally request another medication during the procedure. Medications given from the sterile table must be accurately recorded in the operative record. So in these instances, the medication is obtained as soon as it's requested, it's labeled, and then it's kept on the back table until the surgeon is ready to use it. Traditionally, there were only 5 rights. Remember, we said the 5 rights. However, it's also equally important that the type and amount of each medication used is documented on the operative record. So, it's the responsibility of the surgical tech to keep track of the amount of each medication that is used on the sterile field. Some medications the surgeon will maybe only use once, but there may be other medications that are used repeatedly during the procedure, like local anesthetic, for example. One way to keep track of what is used is to use the sterile marking pin on the field, perhaps right on the back table, or an empty glove wrapper to keep a written tally of the amount of medication that was used during the procedure. Because at the end of the procedure, as the surge tech, you are going to have to verbally state the amount of each medication administered, and then the circulator is going to document that in the patient's operative record. Remember the scrub and the circulator that we talked about earlier? They definitely share the responsibility for correctly identifying medications, and the circulator is responsible for the early steps in the process, such as reading the medication's label and reading the label out loud to the scrub tech, which are the first 2 steps in the medication identification process. It does follow a distinct step-by-step process, and you can see that in box 4.3 in your textbook. So first, the circulator is going to read the label. They're going to get the medication, they're going to read the label to themselves, make sure that it matches with the preference card or what the surgeon is asking for. Then they're going to read the label aloud to you. Then the circulator is going to show you the label and you're going to state the medication information out loud. Then you're going to accept the medication and label it immediately. So, following a distinct logical process is just another way that the medical team can help avoid mistakes. Trust the process. Don't cut corners. Don't skip steps. Don't get complacent. Don't let others rush you into skipping steps or making a mistake. Figure 4.7 shows some samples of medication packages like vials and ampules. And figure 4.8, you can see how the scrub surgical tech may drop the medication from a vial held by the circulator. It's important to remember that we are going to apply the principles of aseptic technique when we are either delivering or receiving medications from, onto the sterile fields. Very important. The circulators are going to use sterile technique when preparing the vials for delivery on the back table. If it is a vial and it has one of those little stoppers, we want to make sure not to touch the vial at all when removing that stopper. If the circulator is drawing up the medication, or whoever in the non-sterile role, you want to make sure not to touch the plunger. Just keep your fingers on the end. If you're drawing up medication as the surg tech, you want to keep your hands as far away from that vial as possible. You want to make sure that you have the measurements of the syringe turned towards you so that you can see them, and keep your fingers back on the end of the plunger, right? You can also take a look at figure 4.10 for an example of a sterile disposable pour spout. So back in the day, and even still now, when we have these glass vials with the metal rings and the little pop tops, a lot of times they'll pop off the top, and then they'll find some sort of scissor or hemostat, and they're going to pry off that metal cap, and that's going to leave the stopper in there, and then they peel the stopper off and pour the medication onto your field. But there's a lot of opportunity for contamination when they're using that process. So the best practice is to use some sort of decanter where they pop the top, they stick the decanter into that rubber part that's in the center, and then they pour it or dispense or decant it onto your sterile field, which is a much better technique. We also might have to work with glass ampules, and we have to be really careful when we have those glass ampules on our field and we're breaking off the tops to not cut ourselves with the glass or breach our glove at all. The glass vials I'm most familiar with is in orthopedics when we are using bone cement. And we have the two glass vials with the liquid component, and you have to snap those off. I always get a blue towel and put it in a blue towel and snap it off, which kind of helps protect my hands and those sort of things. So we might be working with glass vials. Also, like I said before, some topical medications are fatal if they get accidentally injected into the patient. So we never, ever want to draw up a topical medication into a syringe. So most drugs used in the sterile field are clear in color. I might have mentioned that before. And so they can be easily confused if they're not clearly marked. The Joint Commission National Patient Safety Goals requires that all medication containers in the sterile field be labeled. All right, they all need to be labeled. If they are not labeled, this constitutes negligence on the part of the surge tech. So I want to make sure that we label all containers, and that applies to all holding containers. Even if you're going to receive it into one and you're going to completely draw it up into another, label all of those containers that the medication is going to touch, even intermediate storage containers, right? Don't skip any steps. Now, a lot of times in your packs, you'll find pre-printed labels, and these are really good because they're printed out nicely, they're easy to read. You want to make sure that they say the correct thing. And sometimes it'll say lidocaine, and then it'll give a little line where you write in like 1% with epi or something like that. But sometimes those aren't available, or they're not exactly what we need, and we have to handwrite one. If you don't have any labels, steri strips are a good substitute. If you take a look at figure 4.13, you'll see an example of some pre-printed medication labels. All solutions on the sterile field, including medication, saline, water, should be labeled with the name, the strength, the dosage, and the expiration at a minimum. A side note here. We want to avoid pre-labeling our containers or items, and what I mean by that is that it is a best practice to wait until you see the medication label to write your label and place it on the container or the item. If you're working with Dr. Smith and you know Dr. Smith always uses 0.25% Marcaine with epi, do not pre-write your label. It is best practice to wait until you verify that label with the nurse to write your label and then put it on the container. Sometimes there's additional shenanigans required to prepare a medication that is on our field, and the preference card might say, for example, that the surgeon wants 2 medications mixed together. The surgeon might want 1 milliliter of dexamethasone mixed with 20 milliliters of 0.5% Marcaine. Other times, the surgeon may want a medication diluted. I worked with one genitourinary surgeon, and he always wanted 60 mLs of contrast diluted with 60 mLs of saline irrigation for his cystoscopies. In other instances, and this is the picture that you see on your screen here, some fibrin glues, such as this I think is Tisiel, but they have to be prepared on the back table and then drawn up into a syringe before it's ready to give to the surgeon. So it's the best practice if we label each container for the origin of the medications, and we want to take special caution when handling controlled substances in surgery. My suggestion is that you make sure that you understand the policies and then act accordingly. So the most common type of syringe tip that is used in surgery is called the Luer lock tip. There's also the slip tip where the hypodermic needle just pushes on and it pulls off. But most commonly in surgery, we use the Luer lock one, which you have to actually screw the hypodermic needle into the syringe and it kind of locks in there. If you look at figure 4.15, you'll see some examples of different types of syringes, and syringes used in surgery typically range from those that are 1 milliliter to 60 milliliters, but 10 milliliters is typically the most common one. If you look at figure 4.16, you'll see some other examples there. Tubex syringe, a glass carpule, and a needle there. A carpule is a glass tube, and it has like this little rubber cap, and it's penetrated by a special needle that's attached to the Tubex syringe to make it work. Specific syringes are also used for specific purposes. One thing that comes to mind is, let's say the surgeon wants an amount of medication that's less than 1 ml. Then we're going to use the tuberculin syringe because it only holds 1 ml, but then it's broken down into like 0.1, 0.2, 0.3, 0.4. So you can draw up a fraction of a milliliter and get pretty close to the correct amount. Hypodermic needles. That's what we use to draw up and administer medications, and they vary in diameter and length. So it's kind of weird because the smaller numbers are bigger hypodermic needle gauges. So a 14 is going to be bigger than an 18, which is bigger than a 22. So as the numbers go up, the hypodermic needle is actually getting skinnier. It's a smaller gauge. So a 27 gauge needle is very, very small when we compare it to like a 14 gauge, which is enormous. What else do I want to say? Most hypodermic needles that we use in surgery are disposable, and you can see here that they have these pretty colors. Unfortunately, they're not universal. So some places you may have 25 gauge needles that are blue, and other places they might be a different color. So anyways, which is kind of irritating, but the 3 that we use the most frequently in the field are the 18 gauge, which is typically pink, the 22 gauge, which is like a grayish brown kind of color that you see here on the screen, and then the 25 gauge, which is blue. And usually we use 1.5-inch hypodermic needles, but there are 1/2-inch. We typically don't use those very much. So 1.5-inch and 3-inch, which we refer to as spinal needles, are the most commonly used. And it's typical, if we're going to draw up a medication, we usually use a bigger needle, like an 18 gauge, and then we're going to switch it to a smaller gauge to inject the patient, because we don't want to inject the patient with any bigger of a needle than we absolutely have to. Even if they're asleep, it's still going to leave a big poke hole, and we don't want to do that if we don't have to. So lastly on the list, sharp safety. Standard precautions state that we should never, ever in a bazillion years recap a hypodermic needle. And if you are asked this on a test or on your certification exam, you say, needles are never recapped, okay? Promise me that you'll do that. However, this is where practice sometimes differs from what the policies and procedures say, and you might see others recapping needles. And if you're gonna recap, you never want to use 2 hands. You don't want to take the needle, hypodermic needle in one hand and the cap in the other, and put it on, right? Because a lot of times we miss and we could get poked. So definitely, if you're not sure about this, look to guidance from your lab instructors and your program director. But instead, what you would want to do is what we call a single-handed scoop, or a one-handed scoop method. And I put it on the slide here. So this entails placing the cap on a hard surface, and then you're going to just take one hand with your syringe and your hypos on it, and you're going to scoop the cap up with the needle, and then you're going to use that same hard surface to push to secure the cap. And the reason I mention this is that it is unsafe to leave an uncapped needle just hanging out on your sterile field. I had a situation, I wasn't even a year into my career as a surgical tech, and I was helping with a cholecystectomy. It was laparoscopic, and I had passed the local anesthetic to the surgeon. He had in the port at the umbilicus, and he was injecting for the port under the xiphoid process, and I was holding the camera. So I only had one hand to do whatever I needed to do. Again, I was a very novice surgical tech. He tossed the local anesthetic, not in a mean way, but just kind of getting it out of his hand. He tossed it up onto the Mayo stand, and I didn't realize that when it landed, like the hypodermic needle was poking up. And when I moved my arm across the Mayo stand to get the next thing to get the scalpel to hand to him, the needle poked through my surgical gown and poked right into my arm. So thankfully nothing nefarious came from that, but if I would have at least taken 1 second to just put that needle into the cap, even if I didn't secure it, I would have saved myself a poke. So if you don't have time to do the one-handed scoop, at least complete the first step where you just insert it into the cap, and then later you can come back and secure it on. But just make sure that you don't ever leave an uncapped hypodermic needle unless maybe you isolate it way back on your back table. Something else that we might have to do is refill a syringe. If you're using a 10 ml syringe and the surgeon is injecting local anesthetic, Siri's trying to get in on the lecture. You might need to refill that syringe. So that is going to mean you're going to need to recap the needle with the one-handed scoop, remove the hypodermic needle from the syringe. Now, you might need to use a hemostat to do this because sometimes they kind of get stuck in that lure lock. So a hemostat is works well to get that hypo off there instead of your fingers. Then you refill the syringe, then you put the hypo back on, all right? And then you're locked and loaded, you're ready to go again. Now, the text indicates that there are some specialized self-shielding needles that are available for use from the sterile field, but I've never worked at a facility that has used those. So that concludes this lecture regarding medication administration. As always, thank you for following along. I will see you next time. Take care.